Good evening, everyone, and thank you for joining our Men's Health webinar. We'll start with a few housekeeping items, and then I'll introduce tonight's speaker. First, your participation in tonight's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speaker. If you wish to ask a question, please type it in the chat box at the lower part of your screen, or if you're on your mobile phone, just tap your screen and a toolbar will show up and you can click chat. We will address the Q&A portion at the end of the presentation. Our presentation tonight will last for approximately 1 hour and will be presented by Dr. Ryan Dornbier of Urology Center of Iowa. Dr. Dornbier was raised in the Des Moines area, and he received his undergraduate and medical degrees at St. Louis University in St. Louis, Missouri. He completed his urologic residency training at Loyola University Medical Center in Chicago, Illinois. Following residency, he completed specialty training in male genitourinary reconstruction and men's health, also at Loyola University Medical Center. He and his wife returned home to Iowa to begin practice and raise their children. Dr. Dornbier treats all aspects of urology with a specialty focus on urethral stricture disease, erectile dysfunction, male urinary incontinence, BPH, and prostate cancer survivorship. He was drawn to urology by the wide diversity of conditions and opportunity to help his patients improve their quality of life with treatment. Thank you again for joining us tonight, and now I'll turn it over to Dr. Dornbier to get us started.
Thanks, Annie, for that introduction. I appreciate it. Thanks, everyone, again, for coming out to listen to hopefully this informative talk about men's health and the treatment options, a little bit of overview in terms of erectile dysfunction. As Annie mentioned, coming back to Iowa now, I've been here actually for almost 1.5 years at the Urology Center of Iowa. We do have multiple locations around the state now and continue to kind of grow and expand. Our main office is over in Clive, while we also have a clinic out at Broadlawns, and I do see patients now in Pella. So please reach out to any of those numbers if you'd like to schedule an appointment. As Annie said, this talk does require or encourages participation. I try to leave a good amount of time at the end to answer any questions that you might have about treatment options or about any myths that you might have heard or would like dispelled about erectile dysfunction and the treatment options. So please do ask any questions that you have, and I will address them at the end. So goal is to understand erectile dysfunction and the treatment options. And so as any talk with any medical condition, you really want to know what is it, who gets it, and what causes it. So purely based on definition, erectile dysfunction is the persistent inability to achieve or maintain an erection firm enough to have sexual intercourse. And a lot of times you'll see definitions where it says satisfactory sexual intercourse, because it is very subjective to the patient and their overall quality of the sexual experience. In terms of how prevalent is it, these numbers are accurate, but probably a little bit dated. A lot of them come from what was called the Massachusetts Men's Health Study of Aging that came out in 1994. So 1 in 5 American men over the age of 20 years will experience erectile dysfunction in their lifetime. It's probably much higher than that. More than half of men over 40 have some degree of erectile dysfunction. It is quite a spectrum in terms of no erectile quality at all versus maybe just a slightly diminished rigidity to the erection. Affects approximately 39 million American men. Again, probably a little bit higher in terms of overall number, but that is to say a very prevalent condition. So what needs to happen in order to obtain an erection? So it's a stimulatory process that when aroused, the nerves surrounding the penis become activated. It allows dilation of the blood, of the arteries to the penis that allow blood inflow. And really what it comes down to is you need 2 aspects of erectile function in order to achieve and sustain an erection. And that's blood inflow, and then what we call blood trapping, where the venous system collapses and allows the the blood to remain in the penis to ensure that you maintain rigidity. So anything that disrupts those two processes, either the blood inflow or the venous trapping of blood inside the penis, can result in erectile dysfunction. Sometimes it's a difficulty achieving an erection where you don't really get any engorgement at all, or ultimately don't become fully erect, or it's you feel engorgement but it can never really sustain. You get erect, but then it goes away quickly. The three main physical causes are vascular, diabetes, and medications. There are multiple. Basically, the vascular anomalies are in terms of difficulty or arterial insufficiency, difficulty getting the blood into the penis. Diabetes creates vessel hardening, which makes it difficult to get blood into the penis, but also makes it difficult to trap the blood in the penis. And then some medications, whether they're high blood pressure medications or antidepressant medications, can lead to erectile dysfunctions from a medication standpoint. The other aspect is post-prostate cancer treatment. Any man who has had his prostate treated for prostate cancer related reasons will likely have some degree of erectile dysfunction related to some nerve damage, as well as altering the blood flow to the penis. So why is erectile dysfunction such an important aspect of a man's life? And we all know that quality of life and sexual quality of life are important things for men and for couples and relationships, to be able to maintain mental health, to be even able to maintain physical health, that all wrap into that overall quality of life. And we know that erectile dysfunction has broad negative impacts on a man's overall quality of life, not just sexual quality of life. So getting down into terms of how specific disease processes result in erectile dysfunction, when we talk about diabetes, it really is that two-hit idea of difficulty getting blood into the penis, but also difficulty trapping blood in the penis, which often results in difficulty A, achieving, and B, sustaining an erection. So diabetes is very prevalent in the United States, with about 15.5 million men. Men with diabetes are likely to have erectile dysfunction about 10 to 15 years before someone who has erectile dysfunction that's non-diabetes related. They're going to be less responsive to oral treatments. And sometimes in men, erectile dysfunction is actually the presenting sign of diabetes. So it increases your overall risk of heart disease, and we'll talk about this a little bit more in a minute in terms of how diabetes hardens vessels. And when it comes to the size of blood vessels in the penis, they're just a little bit smaller than everywhere else in the body, including the heart. So you often see a correlation between diabetes and heart disease, as well as diabetes and erectile dysfunction. So kind of going on to that heart disease aspect of things, and this is one of the important ideas that any younger man with erectile dysfunction should be aware of, is that erectile dysfunction can sometimes be a warning sign of more serious cardiovascular issues. Erectile dysfunction symptoms often come before heart-related symptoms by about 2 to 3 years, and when you have that initial onset of erectile dysfunction, there's an association about 3 to 5 years, you're at increased risk of cardiovascular events. So therefore, it's important that if you do have erectile dysfunction at a young age, you understand the cardiovascular implications of that and have yourself routinely followed and checked. And that comes down to this overall idea of the size of your blood vessels. If there's blood vessel narrowing related to vascular plaques, it's going to hit the smaller blood vessels first. And like I mentioned before, the blood vessel to the penis is smaller than the blood vessel to the heart, surprisingly. But at the same time, you're going to have that narrowing of the penile artery before you have narrowing of your cardiac vessels, and therefore you have that pre-cardiac symptom of erectile dysfunction as the blood vessels thin. So one of the ways you can reduce your risk of not only cardiac issues, but also erectile concerns, is to overall change your lifestyle from a lifestyle that's less sedentary, meaning more exercise and physical activity, changing your diet away from a westernized diet that's high in salt and high in red meats to a more Mediterranean diet, which utilizes more fresh fruits and vegetables. Weight loss, quit smoking if you're a smoker, reduce stress, and if you're a diabetic, controlling your blood sugars. Another possible cause of erectile dysfunction is prostate cancer and prostate cancer-related treatments. A lot of this relates to what we call a prostatectomy, which is a surgery that is utilized for prostate cancer eradication. So in order to remove the prostate, you have to disrupt some of the nerve supply to the prostate, which ultimately provides neurological input to the penis, which then can lead to post-operative or post-prostatectomy erectile dysfunction. Even with more advanced surgical techniques, we do see what's called a nerve sparing procedure. We do still see erectile dysfunction after a prostatectomy that can be persistent even years after the prostate has been removed. So sexual dysfunction after any prostate cancer treatment is very common, as we discussed with robot-assisted radical prostatectomy, which is the removal of the prostate. About 50% of men after 1 year are going to have some degree of erectile dysfunction. And there's similar sexual dysfunction after radiation treatment. External beam radiation can result in scarring and blood vessel changes that limit the ability of blood inflow to the penis. So with all these causes, it's good to know that there are multiple treatments, but they don't necessarily vary based on your cause of erectile dysfunction. There are multiple people who do treat erectile dysfunction. It's a conversation to have with your general practitioner to start. They can often start you down a pathway to say, hey, let's see if this works. And if it doesn't, then they can refer you to our urologist or a prosthetic urologist who has a little bit more clinical know-how for the steps further down, what is a pathway in terms of erectile dysfunction treatment. So these 5 options have kind of been the mainstay of erectile dysfunction therapy for a long time. Oral medications, Viagra, Cialis, what are called PDE5 inhibitors. They've been around since the early to mid 90s. Before that, we had penile injection therapy, or what's called intracavernosal injection, which has been around for a long time. The penile implant, which we'll discuss later on, the vacuum erectile device, which has been around, since the 60s, and then urethral suppositories. And we'll talk about kind of the risks and benefits of each one of these. And I will kind of give you my overall opinion on some of them in terms of how effective, but also patient-friendly they are. So PDE5 inhibitors, these are medications, as I mentioned, have been around since kind of the mid 90s when the little blue pill came out, and kind of revolutionized how we initially treat erectile dysfunction, and it made it more accessible to a lot of men who were suffering with ED. The goal of it is to increase blood flow to the penis by inhibiting an enzyme in the endothelial cells of the vasculature to allow them to relax more easily. It does require sexual stimulation after taking the medication, and you do need to time it out a little bit, meaning that you need to take the medication about 30 to 60 minutes before you want to engage in sexual activity. They do have a shorter kind of lifespan, so you can't necessarily take them 6 or 7 hours beforehand because that medication might have washed out of the system. We don't like it when you redose the medications the same day. But in terms of overall effectiveness, if you take all comers with erectile dysfunction and all severities, there's about a 60% success rate of at least achieving a sexually satisfying erection for penetrative intercourse with PDE5 inhibitors. Despite that, they do have some limitations. Men with diabetes are less likely to respond, and men who have had, prostate removal or prostate cancer treatment are also less likely to respond. Certain side effects, which are important in any medication, but especially in a quality of life medication, is that you do have some headaches, facial flushing. You can get pretty stuffed up. Some patients do have some reflux-like symptoms, gastroesophageal reflux, which can lead to some, high stomach pain, some muscle aches and pains. And I do have some patients who complain of kind of a post-Viagra hangover the next morning when they wake up. Things to be cautious about is can drop your blood pressure. It is a substance that potentiates the ability of nitrous oxide to work in the system. So if you already take nitrates for chest pain, then that is a complete contraindication of taking these medications. The biggest issue with them is often the side effects, and then ultimately kind of the timing and the lack of spontaneity associated with them. Vacuum erectile devices. Basically what you need to do is you take a vacuum pump, you place it around your penis, you create a negative pressure system that pulls blood into the penis, and then you use a clamp around the base of the penis to trap the blood in the penis. My caveat to these is that patients don't like them. They buy them. They're fairly one-time expense, but they use it once or twice and they say that was terrible. I don't like it, because what happens is you put the restrictive band around the base of the penis to maintain the erection, and it causes the same. If you were to take a rubber band and place it around your finger, you're going to get red, it's going to get painful, it's going to get bruised, and it's going to get numb. And ultimately, it doesn't have a high repeat use rate, and patients usually look for other alternative once they've started using them. I will say there is a specific indication for these, which is good for penile rehabilitation after a prostate removal, because it does allow to bring blood flow in and helps you maintain length after a prostate removal procedure. So they've been used in post-prostatectomy penile rehabilitation programs. Some of the things I talked about: penile discomfort, numbness, blocked ejaculation. So when you do orgasm, since that band is around the base of the penis and compressing the urethra, you can't ejaculate. They're difficult to use sometimes, and the bruising and the lack of spontaneity is also a problem for some men. Urethral suppositories. So this is a product called Muse, which I don't even know if it's available much anymore. You can get them sometimes from compounding pharmacies, but basically you take an applicator device and put it into the tip of the penis. It goes about 4 centimeters into the urethra, and you place a pellet through the dispenser into the urethra. Basically rub the pellet into the urethral tissue, and then the medication in the suppository acts locally to help dilate the blood vessels and bring blood flow in. Variability and effectiveness about 60%, similar to PDE5 inhibitors. Biggest issue is it causes some discomfort, a lot of burning, irritation to the urethra the first time you pee. It's very uncomfortable after you use it. There are some systemic side effects, including low blood pressure, the discomfort in placing the device into the tip of the penis. The biggest problem with it right now is, as I mentioned, it's difficult to find, because I think the company recently went out of business. Outside of PDE5 inhibitors, the most commonly used, probably conservative option for erectile dysfunction is intracavernosal injection therapy. So what this is, it's a self-directed medication in which you take a syringe and a needle, place it into the erectile body of the penis, and then about 10 to 15 minutes before you want to get an erection, you inject yourself with a medication to help, again, dilate those blood vessels and bring blood flow into the penis. If you look at how effective are they, if you have 60% of men who are responsible to PDE5 inhibitors, you're going to have about 80 to 90% of those same men are going to be responsive to intracavernosal injection. So it is kind of, if we talk about stepwise therapy when it comes to erectile dysfunction, it's kind of that next step after failed medication. Issues, it does cause some penile pain. If you give yourself repeated injections, it can cause scar tissue and fibrosis, which can ultimately lead to worsening of your erectile function. If you give yourself too high of a dose or you have a really strong reaction, you can develop a priapism, which is a prolonged painful erection that needs to be addressed fairly emergently. And then you can have blood collections at the injection site, what's called a hematoma. Reasons for people stopping are usually pain. They don't like needles, they don't like injections, and that lack of spontaneous satisfactory erections. The final kind of piece to this is what is ultimately a great option for patients when it comes to improving your erectile dysfunction kind of on a once and for all basis, what's called the penile implant. So basically what happens is it's a surgical procedure that I take a prosthetic device, typically a 3-piece inflatable prosthetic device, and I replace the erectile bodies of the penis with a inflatable cylinder. I then place a pump within the scrotum, and then a reservoir device or a location where the fluid exists in the system up underneath the muscles or near the bladder. So that when you pump the pump within the scrotum, it transmits that fluid from that reservoir system into the cylinders to allow you to achieve an erection that basically lasts for as long as you want it to last, and you can use it for as long as you want to use it until you hit the deflation button above the pump that then causes the device to deflate and transmits the fluid from the cylinders back into the reservoir. So in terms of effectiveness, once you're out of the postoperative period, you can get a strong, satisfactory erection for penetrative intercourse whenever you want it. It's got a 98% success or satisfaction rate and a fairly good durability in terms of how long that lasts. The lack of revision, or what we call revision free rate, is about 94% at 7 years, about 90% at 10 years, and then about it is a mechanical device, so sometimes they do need to be replaced if they were to break down over time. The most common side effects are it is an operation, and we'll talk a little bit more about that. There are mechanical malfunctions which do require that the device is replaced, or at least a portion of the device addressed from time to time. And then a big risk of any sort of implantable devices, from knee replacements to breast implants to penile prosthetics, is infection. So we are very careful about not introducing that during the operative period. So here's a little bit of an animation that demonstrates how the device works. It'll show you kind of the 3-piece device. Everything is maintained internally within the penis. It'll kind of, you can see the pump and the pumps that it take, and it's showing you the transmission of fluid from the reservoir up into the cylinders, which then create the penis becoming erect. So now the reservoir is deflated, and once you hit the deflation button, the penis goes down. It transmits the fluid back from the cylinders and back into the reservoir. And flash it again. So the benefits of the penile implant, as was kind of mentioned, it's designed to be a permanent solution to erectile dysfunction, meaning that there's no more injections, there's no more medications. It increases spontaneity. The only thing you need to do now to get an erection is pump a device within your scrotum, as opposed to timing out the medications, making sure that your injectable medication is now out of the freezer and thawed. So it increases that overall spontaneity. The erection lasts as long as you desire. You can keep it up for as long as you want, use it for as long as you want, and deflate it whenever you want. Everything is maintained inside the body. There's a high satisfaction rate. There's no interference with orgasm or ejaculation. It's been around for a long time, and there are a lot of patients out there that have had success at restoring their erectile function with this type of therapy. So possible risks, it is a surgical procedure, and any surgical procedure is going to have associated risks with it. The post-operative course for me is I make a small incision above the penis, through which all the components of the device are placed. You're in the hospital overnight, and I do keep a little drain in to suck any fluid out from around the device to decrease your overall swelling and hopefully expedite your recovery. After you're sent home from the hospital the next day, then you come back to see me a couple weeks later, just so I can check on the incision and kind of start teaching you how to manipulate the device without really inflating it or deflating it. And then by about 4 weeks afterwards, the pain and swelling has resolved enough that we can start to manipulate the device and teach you how to use it. And as long as things go well and all those and things look like they've healed fairly well, you can go to using the device hopefully between 4 and 6 weeks after the operation. The biggest risk is infection, happens in about 1 to 2% of men, but with newer devices and newer antibiotic protocols, the risk of infection is decreasing. There's a risk of mechanical failure over time, which requires revision, kind of like we discussed. Some patients have concern about the pump. There is no change to your neurologic sensation. And then the healing process, and I do really equate it to, having a knee replacement. If you think about it, if you have a bad knee that you can't walk on anymore, you get a knee replacement, and you undergo a knee replacement surgery, and you have to rehab your knee so you can get back to walking again. It's fairly similar with an a penile prosthetic. You have a penis that isn't working appropriately or functioning the way you want it to, so you put a prosthetic in, and you do have to do a little bit of a rehab to get through that post-operative period. But as soon as you do, and you're fully recovered, you don't even know it's there, and you can use it as you desire. Just a little bit about insurance coverage. Obviously, there's variability across the board in terms of your overall insurance plan. Medicare does a very good job at covering, so therefore private payers are typically pretty good about covering as well, though that may vary. My office does a great job at authorizing all of these things, and they will let you know if there is any costs that will be passed on to you at any time. So basically, erectile dysfunction, common problem, much more common than we care to talk about a lot of times, but it is an appropriate conversation for you and your physician. There are a variety of treatment options that can either go in a stepwise fashion, where you progress from medications to injections to surgery, or if you're like, hey, I just want to have spontaneous erections again and not deal with all this medication and injection stuff, then the prosthetic is something you can just jump to right away. It tends to be a more permanent solution, and it's something that please engage your primary care doctor or your urologist with if you want to have a more in-depth conversation to help you get over your erectile dysfunction concerns. Again, here's all of our contact information, a little bit reminder of where I trained. I am, Iowa born and bred, and despite my lack of being here for a few years. So please contact one of my offices if you do want to get an appointment. And with that, I'd love to open it up to any questions.